This is part 2 of our high-yield ophthalmology review. In this video, we will continue with clinical cases, focusing on Anisocoria, retinopathy of prematurity, and internuclear ophthalmoplegia, reinforcing key concepts for diagnosis and clinical reasoning. Case 3: A patient presents with incidental Anisocoria, meaning asymmetric pupils. Pupil size is determined by the balance between sympathetic dilation and parasympathetic constriction. This is evaluated by examining the pupils in bright and dim light. In bright light, the parasympathetic pathway is dominant. If there is a parasympathetic defect, the normal eye constricts but the affected eye does not. This increases Anisocoria. In this setting, the larger pupil is abnormal. In dim light, the sympathetic pathway is dominant. If there is a sympathetic defect, the normal eye dilates but the affected eye does not. This also increases Anisocoria. In this case, the smaller pupil is abnormal. In this patient, Anisocoria increases in bright light, indicating a parasympathetic defect. The right pupil does not constrict properly, while the left pupil responds normally. In the dark, both pupils dilate because sympathetic pathways are intact. A small difference may persist due to baseline parasympathetic imbalance. Case 4. A 4-week-old premature infant in the neonatal intensive care unit developed respiratory distress at birth and required surfactant and supplemental oxygen. He was weaned after 1 week. Ophthalmic examination shows abnormal retinal vascularization extending into the vitreous. The question is, what caused this finding? The correct answer is neonatal oxygen supplementation. This is retinopathy of prematurity, a condition seen in premature infants and a leading cause of visual impairment. In utero, low oxygen levels stimulate vascular endothelial growth factor, promoting normal retinal vessel growth. After premature birth, exposure to high oxygen levels suppresses this factor, interrupting normal vessel development. Later, increased metabolic demand leads to relative retinal hypoxia, which triggers excessive production of vascular endothelial growth factor. This results in abnormal neovascularization. These abnormal vessels can lead to scarring or retinal detachment in severe cases. Supplemental oxygen increases the risk by worsening the initial suppression of vascular growth factors and promoting abnormal vessel formation later. Case 5: A 68-year-old woman presents with sudden onset double vision that worsens when looking to the right. She has a history of hypertension, hyperlipidemia, and type 2 diabetes mellitus. Neurologic examination is normal except for impaired rightward gaze. The question is, which structure is affected? The correct answer is the medial longitudinal fasciculus. This patient has internuclear ophthalmoplegia, a disorder of horizontal gaze caused by damage to the medial longitudinal fasciculus. The frontal eye field initiates horizontal gaze by activating the contralateral abducens nerve nucleus, which then communicates with the ipsilateral oculomotor nerve nucleus through the medial longitudinal fasciculus. A lesion in this pathway disrupts coordination between the eyes. The affected eye cannot adduct, while the opposite eye abducts normally. This leads to diplopia. Convergence and pupillary light reflexes are usually preserved because they use different neural pathways. In older patients, this condition is commonly due to lacunar strokes affecting the dorsal pons or midbrain.